This conference will now be recorded.
Good morning, everyone. Today's topic is about cholecystitis, and to be specific, about Acalculous cholecystitis. What is an Acalculous cholecystitis? So, as the name indicates, cholecystitis more commonly is seen due to a calculus, that is gallbladder stones. So, when cholecystitis occur without a pathogenesis of a stone disease, it is called as an Acalculous cholecystitis. So, as of any cholecystitis, it is an acute necroinflammatory disease, and it has multiple pathogenesis and pathophysiologies for occurrence. About 15% of the cases which present as an acute cholecystitis constitute to Acalculous cholecystitis. So more commonly, cholecystitis, that is acute cholecystitis, is common in patients with clinically evident and radiologically evident gallbladder stones in most case scenarios. But about 15% of the patients can present with cholecystitis, acute cholecystitis, without any stone. The more common coexisting illnesses are generalized sepsis, burns, and prolonged recovery from major operations. There is a clear indication here which shows there is an increased stress response in such patients, which leads to Acalculous cholecystitis in those patients. So, in generalized sepsis, that is any wound infection which is unmanaged can lead to sepsis. Same major trauma. This causes increased stress levels in the body. Burns, again a hypermetabolic state, which also causes increased stress response. And any major operations, for example, any laparotomy or cardiac surgery, etc., or prolonged surgeries. For example, laparotomy takes, depending on the structure you are operating, from 2 to any specific number of any specific duration. Cardiac surgery, open surgery, will take from 4 to 6 hours. So that in those kind of long duration surgeries, what happens is again there is a stress on the body. So all these conditions can predispose to acute cholecystitis, Acalculous cholecystitis. So the major differentiation feature is in Acalculous cholecystitis. What happens? Why the patient elicits pain is because of contraction against a immovable object, that is a stone, which is impending into the neck of the gallbladder. So the gallbladder is trying to push the bile into the bile duct, but it is not able to do that because of an obstructed stone. That leads to a pain stimulus to activate. That leads to pain. But here there is no such gallbladder contraction. This is due to inseparation of the bile and biliary sludge, which causes infection and necrosis in the later stages. So the exact cause of Acalculous cholecystitis is not known. So though the above mentioned factors like trauma, burns, sepsis are what do you call a thesis for example. So in patients with those factors, there is an increased acalculous cholecystitis episodes. So the scientists or researchers came to a conclusion that these are one of the predisposing factors to acalculous cholecystitis. So, so the epidemiology, as I said earlier, it is majorly seen in chronically ill patients or critical ill patients and hospitalized patients. So about 0.7 to 0.9% of the patients have undergone abdominal aortic reconstruction. So due to abdominal aortic aneurysm, we do abdominal aortic reconstruction. So in such patients, about 0.9% to approximately take it as 1% of the patients will develop acalculous cholecystitis, and 0.5% of the patients in cardiac surgery, and 4% of the patients who have undergone bone marrow transplantation. Again, it is a very long surgery and stressful surgery. So 4% of the patients, because after bone marrow transplantation, the patient is already in a stress state. On top of that, the patient remains in a what do you call? The patient cannot ambulate. The patient cannot move. So he is in a constant rest. So about 4% of the patients will develop acalculous cholecystitis. And again, as with any major diseases, males are predominant. About 80% of the cases occur in male. So, can anyone say which diseases are more common in female? A specific set of diseases are very common in females and compared to males. Can anyone say? Just guess it. Thyroid. Thyroid is one of the organ which has a strong female preponderance. Any gland or any disease related to hormonal imbalances, those are more common in females. So just remember it like that. And coming to pathogenesis, as with any cholecystitis, the main cause is gallbladder stasis and ischemia. So when there is a formation of sludge in the gallbladder, this leads to bile stasis. That is the same thing in kidney also. Urinary infection or renal stones are caused due to stasis. When there is a decreased outflow, what happens is the bile stays within the gallbladder, which leads to infection. First, it leads to infection and inflammation. When it is not treated or it is not intervened, then develops the ischemia and gangrenous spot later. So due to this stasis and infection, there is an endothelial injury and gallbladder ischemia. So even when the patient is in severe shock and you did not evaluate the patient, there is a chance of perforation of the gallbladder due to gangrenous fall. This leads to very severe complications and mortality. So acalculous cholecystitis, as I said, due to stasis, there is a secondary infection. Most commonly involved organisms are E. coli, Enterococcus fecalis, Klebsiella, Pseudomonas, Proteus species, and bacteroides. So most common ones are the Escherichia coli, Klebsiella, and Enterococcus fecalis. Remember those things. So after the stage of stasis, there is an infection. So after infection, what happens is the inflammatory phase. So in this inflammatory mediators are released, which causes the gallbladder inflammation. So lysolectin is produced from lectin and is a normal constituent of bile. So what happens in this is following trauma or acute stress response, these enzyme can be released into the gallbladder. So it is one of the predisposing factor. So again, dehydration is an important precipitating factor, and in patients who are on parenteral nutrition is when patient can't take his uh, dietary requirement or caloric requirement. Uh, long bedridden patients and who underwent major intestinal anastomosis and etc. In such patients, we keep the patient on parenteral nutrition, where carbohydrates, proteins, and lipids are transfused into his circulation. So that is parenteral nutrition. So in parenteral nutrition, long-standing TPN, there is a chance of developing acalculous cholecystitis in such patients. So the pathophysiology, why the parenteral nutrition causes acalculous cholecystitis is when there is no food bolus or food stimulation in the bowels, what happens is there is an impaired gallbladder movement or gallbladder function. So this leads to uh, stasis of the bile, and again the same pathophysiology of infection and inflammation and gangrene. So coming to the risk factors, just note it down. There, ampullary stenosis is one major risk factor. Bone marrow transplantation, burns, cardiopulmonary resuscitation, cholesterol emboli, coronary heart disease, cystic duct obstruction. These are the main risk factors for developing a acute acalculous cholecystitis. AIDS is one of the risk factor. AIDS, ampullary stenosis, bone marrow transplantation, burns, coronary artery disease, and cystic duct obstruction. There is a minor risk factor for childbirth also, because childbirth is also a stressful state where the mother goes into an acute stress response immediately prior to labor and post in the postpartum period. So that can lead to, in some mothers, acalculous cholecystitis. The other ones are diabetes mellitus, heart failure, infections, major trauma, mechanical ventilation, etc. In which patients do you put the patient on a mechanical ventilation? A bedridden patient or a comatose patient or a patient in respiratory failure. So such patients are always on a long-term hospitalization state. So all these things uh, causes a acute response. So that is why there is a chances of development of acute acalculous cholecystitis. So the four factors which causes onset of ASR, which I have been continuously saying from the start of the class: biliary stasis, systemic inflammatory response, ischemia, ischemia or hypertension injury, and infectious disease. These are the four things which you should remember. మిగతావన్నీ మర్చిపోయినా కానీ ఈ four things you should always remember, that are biliary stasis, systemic inflammatory response, ischemia, and infectious disease. These are the main four factors. So I have said already that HIV can cause acute acalculous cystitis because this is due to HIV induces an immunocompromised state where opportunistic infections does occur. So main things are the cytomegalovirus and cryptosporidium bacteria and Mycobacterium tuberculosis and Mycobacterium avium, etc. The main things are the cytomegalovirus and the cryptosporidium. So this leads to higher risk of developing an acute acalculous cholecystitis. So the histological changes are any inflammation starts in a very uh, manageable level, where if you can intervene and diagnose and treat the patient, uh, you can avoid a major hospitalization phase. So it starts as a mild edema. If at this stage, if you start the patient on an IV antibiotics and NSAIDs, there is a about 90% chances of treating the patient without any major hospitalization chances. So after mild edema, there is an acute inflammatory phase which leads to necrosis and gangrene of the gallbladder. So the clinical features are depending on the stage at presentation. So starting, it is always any inflammatory phase will have fever. There will be abdominal pain in the right upper quadrant. Jaundice in the jaundice is a sign not seen in every case, but it is a indication which leads to you to see for biliary anatomy or something related to the biliary disease. So in the initial stages of inflammation, it will mimic the pain of an acute calculous cholecystitis. So calculous cholecystitis causes a very colicky type of pain. So in the starting stages of the calculous cholecystitis, it will mimic a calculus cholecystitis pain. And as I said earlier, the delay in diagnosis will lead to incidence of increased chances of gangrene and perforation. So the physical examination findings are there will be a palpable right upper quadrant mass. This is due to the distension of the gallbladder. So there is an sludge and in some cases there can be filled with pus also. So this leads to the distension of the gallbladder, which can be palpated in the right upper quadrant. Normally, you cannot palpate a gallbladder. If you palpate it, it can be either due to this type of cholecystitis or carcinoma gallbladder. So the other important thing is the tenderness in the right upper quadrant and Murphy's sign. Can anyone say what is Murphy's sign? You are already in 7th semester. What is Murphy's sign? Any one of you tell what is Murphy's sign? It is a palpatory sign. Always remember, while palpating the right upper quadrant, you ask the patients to breathe in and breathe out. So while you are palpating, you ask the patient to breathe out. Uh, so if you palpate the gallbladder and the patient is inhaling his inhaling, in the inhaling phase of the respiration, there is a sharp pain when the patient is breathing in at the right upper quadrant. This is a palpatory finding and very important finding. So another important point is, so whenever you come across a patient who develops post-operative jaundice, you have done a surgery for cardiac abdominal aortic aneurysm or some long-standing surgery. In the post-operative period, you find the patient in a icteric state, or the patient is having signs of jaundice. So always your first differential diagnosis or first area you should look for is at the biliary system. So it might be Acalculous cholecystitis. So laboratory tests, any inflammation will cause leukocytosis, which is the shift in the neutrophils to the left. In 70 to 80% of the patients, any inflammatory phase will have increase in the neutrophil count. And abnormal liver tests are common in Acalculous cholecystitis, where increase in serum ALP and aminotransferases are seen. And compared to Acalculous cholecystitis, here the liver enzyme derangements can be seen in Acalculous cholecystitis. The major ones are the ALP and serum aminotransferases. So the main modality of diagnosis in a Acalculous cholecystitis is always readily available investigation is always ultrasonography. So the gold standard might be polyscintigraphy, which is also called as IMD scan, HIDA scan, for example. It's called as HIDA scan. But HIDA is called as, what is HIDA? Hepatobiliary. What is HIDA? I gave you the clue, which is HIDA. It is also called as polyscintigraphy. H stands for hepatobiliary or hepatic. Immunodiestic acid scan. So HIDA is an radionuclide scan, and it is not available at every center. So even though it is a gold standard investigation, you should always prefer low cost and most effective way of managing a patient. So ultrasonography is the one we do usually. If the examiner asks what is the gold standard, always say polyscintigraphy or HIDA scan. Again, blood culture can give you a picture of a sepsis. So it is one of the investigation which you can order. If the blood culture comes positive with a certain specific organism, for example, I have said E. coli and Pseudomonas and Enterococcus faecalis. So depending on the organism which is isolated in the culture, you can guide the antibiotic therapy. In ultrasonography, what you see is thickening of the gallbladder wall. In the next coming slides, I will show you how it looks in an ultrasonography. So, if there is an gallbladder thickness of more than 3.5 mm, it is the cutoff. If the gallbladder wall is thicker than 3.5 mm, you should always be suspicious of an inflammatory phase going on in the gallbladder. So it is almost sensitive up to 100%. Even though textbooks will say about 80 to 90%, but it is always in a clinical practice and with experience that I had, it is always indicates a acute inflammation, acute inflammatory phase. So the other ultrasonic features are abscess of gallstones and pericholecystic fluid. In inflammatory phase, there is usually collection surrounding the structure which is inflamed. So in appendix, you will see periappendicular fluid collection. The same way, in if there is an acute pancreatitis, you will see peripancreatic fluid collection. The same way, the ultrasonic features have a pericholecystic fluid collection seen in the USG. And I said earlier that the gallbladder thickness of more than 3.5 mm is an indicative. And Murphy's sign can also be elicited during the ultrasound probe. While the radiologist is probing the right upper quadrant area, the patient can elicit pain. So that is one thing. And another thing is the gallbladder distension of more than 5 centimeters. So the luminal distension of more than 5 centimeters is also indicative of this. So I said about gangrene and necrosis. So in the end stage of these things, what happens is there is an emphysematous cholecystitis, where due to the presence of active infection, gases are released. As it is same in any other diseases or any other closed space infections. So this gives you an gas shadow in ultrasonography. So here this is an USG picture showing sloughing off of the mucosa. So this is the gallbladder wall, where one side of the wall mucosa is sloughing off. So this is due to necrosis. So this is the sloughing of mucosa of the. Usually it will be attached here, but due to the necrosis, what is happening is it is detaching from the mucosa. And this is the picture showing the wall thickening. So here you can see, normally in a normal patient you don't see this much of a thickened wall. It will usually be restrained to only this part of the gallbladder, but there is a about 3.5 mm, for example, showing increased wall thickness of the gallbladder wall. This is a contracted gallbladder, where if while you are doing an ultrasonography, you can always press the gallbladder. If it is contracting, it is not in a calcified state. So there is a thing called as calcified gallbladder because of long-standing and chronic infection and chronic inflammation. The gallbladder wall gets calcified, and it will not be, you will not be able to contract the gallbladder. And always remember that a non-contractile gallbladder is a pre-malignant sign for gallbladder carcinoma. You should always rule out other differential diagnosis or other entities which causes such type of pain and clinical scenario. That is hollow viscous perforation, bowel ischemia, and renal stones. Renal stones can cause a referred pain in many areas of the body. More commonly, renal stones will always radiate to the back and to the groin. In males, there is a patients with renal stones can elicit, and renal colic can elicit testicular pain due to the radiation of the pain. So polyscintigraphy, this is the HIDA scan. So you give immunodiazolic acid to the through intravenous route, which is taken up by the hepatocytes. So the specificity is 100%, but as I said, it is not easily available and it is very costly. So again, CT can be done. It also gives you a good picture. The same thing, the findings are always the same in CT also. So here it is a CT picture where this is the gallbladder, this is the liver, this entire thing is the liver. So, and this is the gallbladder, which is really big. So that indicates a very long-standing inflammation having gas shadows. These are the gas shadows which you see the picture and lead you to a diagnosis that it is a emphysematous gallbladder infection. So there is a gas production from the infection. Here also, so this is the liver. So and this is the gallbladder, and there you can see a black lining, that is the air. This is very polycystic indication. These all you cannot identify at this stage of your career, but as you progress into the PG and post PG, you can easily read a CT, MRI, and ultrasonography. So this is the inflammation and the thickened wall, and there is an fluid collection. This white thing which you are seeing is the fluid collection. This is emphysematic cholecystitis. I have already said this. An MRI is also good enough for the diagnosis, and it also gives you the same picture of thickened gallbladder wall and irregular mucosa, lumen distension, intramural gas, etc. So the differential diagnosis are always acute calculous cholecystitis. For acalculous cystitis, the most common DD is always acute calculous cholecystitis. Then there is peptic ulcer disease, that is duodenal ulcer or gastric ulcer with or without perforation, and right-sided pneumonia, pancreatitis, subphrenic or hepatic abscess, and right-sided pyelonephritis. Pyelonephritis is infection of the kidney. So these all things give you a differential diagnosis. And coming to the treatment, in the early stages, if you could identify it, the major management protocols are always towards medical management, that are initiation of antibiotics with IV route, and if the patient is in an acute phase, you wait for 6 weeks. So you administer antibiotics and anti-inflammatory drugs. If the patient is responding, you wait for another 6 weeks, because if you do cholecystectomy in an acute phase, there will be uh, uh, very high chances of tissue injury while dissecting the everything gets attached. For example, mesentery, bowel, etc. Due to the inflammatory process that is going on in the gallbladder, everything gets attached to the gallbladder. So you should be very careful to dissect that. So if you give the gallbladder a rest, then medical management is achieved and the patient is completely recovered. If you give the patient a duration of 6 weeks approximately, it can also be done at 4 weeks. The ideal is 6 weeks. So after 6 weeks, everything gets settled down in the gallbladder region. So the surgery will be easy both for the surgeon, operative surgeon, and the patients, because complications are less. And cholecystectomy in an acute phase should always be done if the patient has pain today, and if you do the surgery today, there is a very better chance of getting an ideal cholecystectomy. If you do not intervene at that stage, you should not intervene up to 4 weeks. That is a common principle used by surgeons. So placement of cholecystostomy tube is one other treatment choice, where you insert a tube into the gallbladder and drain the infectious fluid or pus which is present inside the gallbladder. So this relieves the symptoms, and as you are already administering antibiotics and NSAIDs, the patient will recover faster. So placement of cholecystostomy tube is another indication in patients where cholecystectomy cannot be done. For example, in older age group, about 80 or 90 years of age, patient develops such type of infection. Surgery is in itself is a very morbid situation, because at that age everything and recovery phases are all diminished. So in such patients, you should always go for minimal invasive things like cholecystostomy tube or something. So if you do surgery, there are high chances of mortality in such patients. So as I said in the starting, there is if there is treatment delay, mortality rates are higher. That is as high as 75%. So if there is treatment, if you intervene at the correct time, the mortality rates decreases 30%. So the antibiotics are again broad spectrum in the starting stage. If your culture comes positive to certain organism, then you can change it to that specific organism. So always we should start with a broad spectrum antibiotic like third generation cephalosporins or penicillins. Most commonly used are the third generation cephalosporin because it gives a very good response. Uh, for example, what is most commonly used is the ceftriaxone. So the definitive therapy is always cholecystectomy, because if you give the patient medical therapy and his symptoms and everything got better, and the patient neglects it, there is a high chance of developing the same sequence after a year or after 2 years, after 3 years, etc. Depending on the patient and his state. So it is always advisable with a patient who develops cholecystitis to go for a cholecystectomy. So here it says the patient with acalculous cholecystitis treated with cholecystectomy should improve rapidly within 24 hours. So surgery is a beautiful thing uh, because of this very factor. So in medicine and other medical departments, what happens is you should wait for the drug, or you should wait for the body to react to the drug. It is a staged procedure. So you should always be in the limbo. You will be waiting for the patient to get better. But surgery, when you are certain about certain disease or a certain thing, you operate the patient and you will see the patient improve like anything in the 24 hours after surgery. So the patient will be free of pain, will be free of his symptoms, everything. So it gives you a uh, major high. So if the patient, if some of the patients are undergone cholecystostomy tube, should always be in place for about 6 to 8 weeks. So if you remove it preemptively, there are chances that he might land up in cholecystitis again, and you should go through the same procedure again. So it is better for 6 to 8 weeks of cholecystostomy tube. Everything gets better. Then you go for laparoscopic or open cholecystectomy. And the complications of the cholecystectomy are like any other surgery, site specific and organ specific. Okay, hemorrhage and sepsis are common, and there is bile peritonitis, because if any bile is leaked from the infected bile which is present in the gallbladder got leaked and falls in the peritoneum, there can be, if you do not wash the peritoneum properly post surgery, bile peritonitis can occur. So pneumothorax is one of the complications of surgery, because as you know, it is in the right upper quadrant. So any mild infection or while you are doing surgery, you will always you will call that as sorry, you will always wash the area with a normal saline. So if you leave remnant NS in the body cavity, it will get dependent area. The most dependent area is in the subhepatic pouch or subhepatic region. If you leave that like that without suctioning out everything, there are chances you can develop a subphrenic abscess. So that is about acalculous cholecystitis. And coming to prognosis, if you intervene correctly, it is good. But if you are the patient present at an advanced stage, so the mortality chances of a patient with gangrene and necrosis is about 70%. So in a patient with gallbladder gangrene, about 50% of the patient will always result in gallbladder perforation. So that is about acalculous cholecystitis. In the next class, do you want surgery? For example, do you want to see laparoscopic cholecystectomy, or do you want me to continue with gallbladder diseases? The choice is yours. If you want to see how a cholecystectomy is done in a acute presentation, there are different cholecystectomies. The process is the same, the surgery is the same, but the presentation intra-abdominally and how it looks is different. For example, in a patient with gallbladder stones without any signs of inflammation, the surgery is very easy to do, because everything is staying as it is in their respective anatomical positions. But in cholecystitis, everything gets attached. So that difference, if you want to see, will show you a video of laparoscopic cholecystectomy or open. One answer I got from Hiteshi. So మిగతా వాళ్ళందరికీ క్లాసే కావాలా? So that's it for today. So we'll meet in the next class. That is on Wednesday, I guess. So we'll meet up in the next class.